I've got you under my skin. I've got you deep in the heart of me. So deep in my heart that you're really a part of me. I've got you under my skin. I try so not to give in. I said to myself, this affair never will go so well.
In Colombia.
Very happy today to introduce Dr. Patrick Kimbrell. He is the medical director of Total Wound Specialists, PA. He's also, the way I know him, as the medical director of the Center for Wound Care at Warm Springs Rehab Hospital. That's over off Medical, just before Babcock, behind Santa Rosa. And he has been director, or is currently director, of clinical operations, fellowship director and professor, was at the Davis Wound Care and Hyperbaric Medicine Division of the United States Air Force School of Aerospace Medicine. He is a diplomat of the Board of Certified Wound Specialists, is a fellow of the American Academy of Wound Management, and a fellow of the American Professional Wound Care Association. If you see his CV, he's got lots of activities that he participates in and a tremendous amount of training. He's a graduate of our own Health Science Center Medical School and has extensive clinical experience in complicated wound management, hyperbarics, and geriatric medicine. He's active in several national scientific societies, chairs several national committees, and is internationally recognized as an expert in the field of wound management. And I might add, he does a lot of research. So that's wonderful. That's how they come up with all these new and better methods of handling wounds, and I think you'd be very impressed with that. He's past president of the board of the San Antonio chapter of the American Diabetes Association, and as you know, wound care is a big issue in diabetes. And I can tell you he has a phenomenal patient manner. He treated my dad and was absolutely terrific. And I'm extremely happy to introduce him.
Thank you. Thank you.
Good.
Well, thank you for inviting me. And the talk I'm going to give, I think, is going to be hopefully very useful to you, because venous stasis and venous ulcers are the #1 problem that you should see out there in the group of elderly patients that you're treating, although there's, of course, other things. The second most common is arterial ulcer. So this is the type of patient if any of you want to look over here, it's a little clearer on your screen, but this is the type of patient that we're going to see, and it's a little washed out, but you can see this is a patient with swollen legs, and there's darkening of the legs, which we'll talk about in a little bit, is called Hemosiderin Staining. So let's talk first about venous insufficiency, because it's important for you to kind of understand that before you can understand why these patients can get wounds, and wounds that are problem healing. It's actually the most common vascular disorder in the world, really. There's over 1 million patients with chronic venous insufficiency in the United States, and that's estimated. It's probably larger. 70% of those patients will sometime in their life get a leg ulcer, and many of them will have problems healing those. 61% report venous stasis ulcers before age 65, but most of them are from age 45 on up, although I get some patients as young as in their 30s that may have it, and those patients have a strong genetic tendency in their family towards venous insufficiency. But most of my patients are greater than 45, and as we get closer into the 60s, the incidence continues to rise. Venous and arterial insufficiency coexist in about 20% of these patients that you're going to be seeing. I think everyone always talks about how whatever they're talking about is very costly, and indeed with ulcer care it can be very costly too. It's estimated that some of these ulcers may cost as much as $40,000 to resolve. And many times it's because these patients are also in and out of the hospital. You'll see in a little bit that there's some things that can happen to a venous stasis patient that looks very much like they have a severe cellulitis when they may not. And so they often get admitted with the thought that they have cellulitis. Of course, that drives up costs. I think from a social standpoint, there's many, many millions of work days are lost annually because of this disease. And impacts the quality of life of your patients. Their ability to ambulate is restricted. Leaving home, anytime they start getting ulcers, they don't want to leave home with draining ulcers, and they avoid social interaction, so it really can change their life. When we look at the piping in our body, we always talk about the veins, which are over there on the left, and in the middle, the arteries, and we're pretty comfortable with general function of the arterial and venous system, the arteries taking blood all through the body and the veins taking it back. One of the things that aren't always stressed to us is that both of these systems, even in very healthy people, leak. So right now you're sitting here, you're leaking. Both your veins and your arteries are leaking into the interstitial fluid. Actually, several liters a day can leak into our interstitial fluid. And so the third system that helps pick that up is the lymphatic system. And the lymphatic system will pick up that excess fluid. It's mostly plasma coming out of our venous and arterial system. And it also brings that back and dumps out right by the heart so that it mixes it back into the system. And so you're going to find that many of our patients that have venous disease and they have tremendous problems with venous edema, they will start overwhelming their lymphatic system, and they'll have a venous lymphatic problem, combined problem. Okay. We're going to talk about the legs because that's where 90% of the patients that you're going to see that have problems with swelling and perhaps non-healing ulcers are going to present is with leg swelling. So the venous system of the legs is actually a very complex network of some pumps, tanks, and monodirectional valves. The valves are the key to understanding what's going on here. We have our superficial veins. Those are the ones that we see in our leg, the ones that are cosmetically important many times to patients, and they're found in the subcutaneous tissue. They're outside the fascia, and they help return venous flow from the skin. Okay. The deep veins are the ones that under the muscles. They're responsible for returning blood back to the heart. So actually, venous flow goes from the superficial, and there's some perforators that will take them to the deep veins, and it's the deep veins that will eventually return the blood to the heart. So you have what's called perforator, communicating veins that connect those two systems, the superficial and the deep veins. Now, to have everything flow correctly, we have valves, and every few inches there's a bicuspid valve, and that valve, if it's working correctly, will only allow flow, cephalad, towards the heart, towards the head. Okay? So when we're born, if all of our valves are working correctly, they only allow flow towards the head in the veins. Okay? And so you can already see that sometimes they don't work correctly, and that's what we're going to talk about. So in a well-functioning venous valve, it prevents retrograde flow. In the large veins under the muscles, the pumping action is partially through the large muscles that surround those veins. Okay, so those veins actually have some smooth muscle and they pulsate, but that is not enough pressure to keep our blood flowing. And so the large muscle groups around those veins as we walk or contract our muscles also help pump the venous fluid. And that's called the venous pump. Okay. So what normally happens is when we're walking, the calf muscles flex, they compress the deep veins, and it helps push the venous flow back towards the heart. Of course, the heart, pressure of the heartbeat also helps with that. And there is some smooth muscle that also pulsates and helps. Okay. As the calf muscle relaxes, okay, that flow stops, and it actually allows the perforator veins to open because you drop the pressure, perforator veins will open, and you'll get flow from the superficial to the deep because now the pressure's low. And then as you start walking again and your heart beats, the perforator vein valves close, and then all of that blood that's in the large, deep veins are pumped back towards the heart, and it's just a constant cycle. You have a group of patients, if you ever do rehab type things, and I see those patients, they are immobile, especially if they're paraplegic or quadriplegic. So over time, even if their veins valves are okay, they'll start getting edema because they've lost that muscle when they start getting edema. And so it makes sense once you understand how this system works. So failure of the calf muscle or failure of the valve can cause problems. And the most common thing is valvular incompetency leading to venous edema. Okay? DVT, deep venous thrombosis, accounts for a large group of those patients, but it's not all of them. Things such as childbirth can cause stress on those valves, and later on in years you can have venous stasis because of childbirth. I get a lot of men who were football players, basketball players, sports oriented, and they bashed up their legs whenever they were in their teens and 20s and 30s, and then by the time they're in their 50s and 60s they're starting to have valve incompetence because of that trauma has caused some of those valves to malfunction, and so they'll start getting venous stasis or edema of the leg. But anyway, anything that causes the valve to go bad leads to them leaking, and you start building up consistently high pressures in the venous system, because now the blood tries to go forward. Some of the valves are incompetent, so whenever the heart stops beating, some of that blood rushes back down into the legs, some of that venous blood, and it starts increasing the pressure. That's venous hypertension. Finally, when the pressure gets high enough, it's going to start leaking, just frankly leaking out of the veins. We already know the veins, even at baseline, leak, so you can imagine as the pressure starts building up to normally high levels, you're just going to start leaking through the interstitium of the veins, and it's going to end up with plasma in the tissue of the legs. And that's what you see clinically as venous edema or swollen legs. Other things that happen is the legs become edematous. Remember, this is protein, fluid. There's a few red blood cells, a few white blood cells that leak out in that fluid. But as you start getting edema, you're going to see a few things clinically. Number one is you'll go down to the bottom. Some of those white cells will start trapping in the tissue, and they'll let out their mediators, free radicals, and they'll start causing some inflammation of the legs. Okay? As you start increasing swelling in the legs, the skin becomes further and further away from the arterial blood supply. And so now you have skin that is relatively hypoxic because you've got all this fluid between the arterial blood supply, which is supplying oxygen in the skin, and so you have a relative hypoxia. You're already setting yourself up for problems if that skin should become damaged. Okay? So you'll start getting a relative reduction in oxygen primarily to the skin. Of course, that's where we could eventually have an ulcer. And so you'll have a patient, again, like this. The other thing that will happen is, remember I said a few red blood cells leak out in that fluid. Those red blood cells get trapped in the tissue. They die, and what do they release? There's two major pigments. Hemoglobin, which is iron, got a lot of iron, and melanin. Those are two major pigments that are in red blood cells. And so you'll start seeing these patients when they have chronic edema start getting darkening of the skin. They're actually kind of like rusting. The skin is rusting. And that hemoglobin and melanin, that iron and melanin that's deposited in the skin, not only causes the darkening cosmetically, it causes the skin to be, it changes the skin in such a way that if it's damaged, it's going to have a harder time healing. Because now you've got all these things that are causing inflammation. The fibroblasts start increasing abnormal collagen deposition. You start getting hardening of the tissue. And so some of these are the signs that we see that form in these patients who've had chronic uncontrolled venous edema. So here we go. Hemosiderin staining is the staining from the red blood cells. Lipodermatosclerosis is hardening of the tissue, fibrotic tissue, of a waxy look, a very hard hardening of the tissue, and that's because now you have so many inflammatory products, like protein, red cells, hemosiderin in there, that the fibroblasts react and they start laying down excess collagen, and so the skin starts thickening. And I know you've seen this in patients that have had long-term edema in their legs. These are some of the signs. So here's someone with chronic lipodermatosclerosis, and of course this is an extreme case, but when you feel it on exam, it's just going to be very thickened, kind of irregular feeling of skin. Because now you've got all this fibrosis sort of holding the edema in. It doesn't have that normal tight, shiny look that it might have had 3 or 4 years before. But they still are edematous.
When the patient is in that stage, the edema, the patient has eating edema or not?
They can, but they may not.
Sometimes you increase the lymphitis.
Right. Well, and many times they have a
They both-
concomitant lymphedema because they've had so many years of excess fluid, and what is trying to, all that time trying to drain that fluid? The lymphatic system, right? Now you've stressed the lymphatic system for 5 or 10 years, and you're right, and then the lymphatic system starts giving out, so they may actually have venous lymphatic edema. They're both treated the same way is the good thing, okay? But yes, it may get to the point where they no longer pit because they're so fibrotic. And so you have to be able to recognize that this is an advanced case. And usually the patients will have this history of kind of an insidious onset of swelling 10, 15 years ago, slowly worse over years. And they get kind of used to seeing their legs like that. And so they don't necessarily complain a lot about it. Okay, here's something that is very important for you to understand, and that's venous dermatitis. Okay? It's a frequent finding in patients, and you'll see this dermatitis. It'll be an erythematous warmth of the usually the anterior shins, maybe in the ankle area. It's often, in fact, most of the time, it's bilateral. Okay, so you'll have both swollen legs with this just beet red look to them. Okay, they'll be warm, they may be itchy, and it's easy to mistake for cellulitis. Okay, but I will tell you, stop, and when you see that in a patient, these edematous legs, a history of long edema, they may have a history of this dermatitis coming and going, and they're usually not, for the severity of the erythema, they're not toxic, they're not septic. But we're very used to, in the medical profession, when we see something, and you can't see it too well there, but you can see it here. When you see something that erythematous and warmth, the first thing that you're going to think about is cellulitis. One thing I want you to remember, the chance of getting a cellulitis in the exact same place at the exact same time in both legs is very unlikely. Okay? So when you see that, first cellulitis should be in your differential, but start thinking too, is this a venous dermatitis? Because these patients will often get admitted for $30,000 worth of IV antibiotics, and really what they needed was control of their venous edema. They will get better during their hospitalization because they're in bed most of the time instead of running around at their house. So their edema gets better, the dermatitis gets better. They go home, and a week later they call their doctor and said, that redness is coming back. And the doctor, puts them on another antibiotic really quick. And I'll get the patient, the history is, Dr. Kimbrell, they've put me twice in the hospital for IV antibiotics. I've been on 5 different oral antibiotics. It gets better when I'm in the hospital, but it keeps getting worse as soon as I get out. Okay, now you can see, when you know a little bit, you start saying, whoa, that's because the edema's returned. And I said, yeah. And so, be suspicious. You can save your patients and the system a lot of money and heartache if you correctly recognize this problem, venous dermatitis. Okay. So that is venous stasis. Now let's talk about venous ulcers, because a lot of patients will go with years with venous stasis and may not get an ulcer. And then all of a sudden they may get an ulcer. It's a major complication of untreated or poorly treated or venous stasis. It accounts for 76% of all problem ulcers out there in the world today in the United States. So it's a large group of patients. Okay? 61% of these patients will present between age 45 and 65 with their first ulcer, but many of them will have recurrent ulcers over the years, and you'll see in their legs these scarred areas, and it took 1 year for that ulcer to heal. They may or may not have been treated correctly. This is a very severe ankle ulcer. Trauma is the most common cause. Okay, a lot of times they'll tell you, I don't know what happened. I just had a little pimple there and it got worse and worse. Most of the time it's actually trauma. A lot of these patients are maybe in wheelchairs, they're banging themselves during their lifestyle. They'll get some little minor trauma that usually should not cause a problem. It's often in the ankle, calf, anterior shin. they have venous edema, they have perhaps some level of lipodermatosclerosis, and more importantly, most of the time their skin is relatively hypoxic because their edema is such that the skin is so far away from the arterial supply that they're not getting good diffusion of arterial flow, and they're not getting much nutrients, right? If you don't get much nutrients and arterial flow to a minor skin wound, what might happen? Won't he? It'll deteriorate, in fact, okay? And so that's what happens. It's innocent type of trauma, and suddenly it just keeps getting bigger and bigger, and they see their primary care, and they do the usual things, antibiotics and kind of topical, and it just keeps getting worse. And these will often be wounds that drain. They have to change the dressing 2 or 3 times a day because they're draining. You've got a hole now in a leg that's swollen, and so where is that fluid going to go? Right out the hole, and so they'll be draining. So they fail to heal in an orderly fashion, and they become a chronic non-healing wound. Sometimes they'll have a history of this dermatitis too. So it can be a very simple, and I apologize for the way they're coming up on the screen, but there's a very simple wound, and that can get very large over a matter of weeks or months if untreated. This is a more classic venous ulcer. They will have, instead of having the bright red granulation of a healthy wound, they'll have a purple granulation. Why would the granulation tissue be purple? Good thought. Good thought. The biggest thing is because they're engorged with plasma. So you've got all these little vascular loops, and there's so much leaking fluid and plasma, it engorges that neovascular tissue, and it gives a purple hue to it. And so purple-looking granulation tissue in the swollen leg with other signs of venous stasis, start thinking this may be a venous ulcer. Another set on there. And they'll often have slough in it, kind of a yellow slough. It may be kind of a purple granulation tissue with some yellow slough. The yellow slough is the plasma leaking out, and the plasma dries, and it turns into a protein slough, a yellow slough. Okay. So, assessment. It's a clinical determination. Once you've truly become comfortable with assessing these patients, you can make the diagnosis clinically. It's just you have to know what to look for in your history and physical. Yes, sir.
With this Gero's law, it's curious because in the past when I had burn people, second degree, they lost a lot of that. So if you're not infected and you smell, they smell like egg. And it's because the patient is losing a lot of albumin.
Correct.
But we are very tempted to, anytime that we see this kind of exudate, to put on antibiotics because we are thinking that it's infected.
Yes, I know. You're right. That's what happens. And you're correct in the assessment. Burn patients also lose a lot of plasma because we all have some plasma in our tissue, and if you lose your skin, it starts leaking out. It's the same thing, though. It's just more severe in a venous patient. Okay, clinical assessment. Look for that history and physical. You got swollen legs. Ask the patient, well, how long have you had problems with swelling? And the first thing they're going to tell you is, it's only been bad for the last 6 months. Well, you see hemosiderin staining, lipodermatosclerosis, you know it's been there more than 6 months. What really happened is something happened and they got significantly worse. So you'll say, well, you didn't have any swelling before that? Well, no, you know, I have had swelling for quite a few years, maybe 10 years, you know, and it's gotten slowly worse. And these patients get used to seeing their legs swollen. Okay? It starts out with a little swelling in their feet 10 years ago, and then got better whenever they went to bed at night, and then a couple of years passed, and then they noticed it was in their ankle, and then finally in their calf. And it got better when they went to bed or elevated their legs, and then finally it quit getting better or didn't completely resolve. And see, they're getting worse and worse, so it progresses slowly over years. So it'll be insidious in onset, but they often will say, no, you know, it was right after I had that chemotherapy. Well, chemotherapy will make you leak worse, and if you already have venous stasis, now you put chemotherapy on, that's an acute event on top of a chronic event, so they'll notice it then, but when you really question them, you'll find that really they had some swelling many years ago, and it's just progressed. It's usually below the knee when it first starts, okay? Venous stasis is a disease that becomes clinically symptomatic below the knee. When it is crossing above the knee, here's a little pearl for you. That means now you are having destruction of the lymphatics. Okay? Lymphedema often will progress above the knee. So I'll often get a patient who has a history of venous stasis for many years, but it's just recently started getting swollen above the knee, and that is a sign that they've had swelling for so long they've started to destroy their lymphatics. And so now the edema is crossing above the knee. Okay? Heavy aching feeling. They may have a history of recurrent ulcers that were slow to heal, and now maybe they're not healing at all. Maybe they healed over 6 months 5 years ago because their edema wasn't quite as bad, but now it's much more severe and they may not be healing at all. Okay. Risk factors. DVT history is seen in about 37%. So a third of the patients may have a history of DVTs. Okay? Leg trauma is another risk factor. Surgery, pelvic surgery. What's a big surgery in the legs? Knee replacements, right? Okay, so a lot of those patients, you have to cut through the venous, some of the venous system, and they may end up with venous insufficiency. Hip replacements and pelvic surgery. These are all things that interrupt and can cause damage to the venous valves, and later on in years, they may present with venous stasis. Standing jobs, physicians, nurses, anybody who has a long-standing job, we put tremendous stress on our venous valves, so you guys should already be wearing over-the-counter so that you won't, at age 60, start having problems with venous stasis. Obesity and pregnancy, especially multiple pregnancies. And we know that many of our pregnant women, they start getting edema at the end because they have so much abdominal pressure from the fetus. It's causing venous obstruction, puts back pressure, and that causes damage to the valve. So those are all risk factors that may lead years later to them have frank venous stasis. Differentiate their ulcers from an arterial ulcer. Okay, we showed you a venous ulcer, which is usually kind of a purplish granulation tissue, not much eschar, may have some yellow slough, may have some hemosiderin around it. It'll definitely be draining a slightly amber viscous fluid, that's protein, versus an arterial ulcer, which is going to have a necrotic area, because that is frankly ischemic. I mean, it's going to be more of a necrotic, tender wound, although venous ulcers can be very tender. Okay, so that's one of the things you want to differentiate. Patients with venous ulcers, 20% of the time will have also concomitant arterial disease, significant arterial disease. So you can have a mixed venous arterial ulcer too in some of these patients, and we'll talk more about how you treat those different in just a minute. Okay, what's the medical management? Everything we've talked about happened because of venous hypertension, right? Because pressure started going up in the venous system, incompetent valves, losing the proper functioning of your pump in your leg, and pressure goes up, edema, and eventually you are at risk for venous ulcers. So the first thing we need to do is we need to control venous hypertension, or we need to control the edema. That's number one. You can get the ulcers and care for them and do the best wound care, but if you don't control that venous edema, they may not get better. Okay? So that's the first one of the high things that should be on your mind whenever you're managing this patient. And then you'll be able to, of course, treat any infection that might be there. Treat the dermatitis. Well, I will tell you, when you start reducing the edema, the dermatitis will start resolving. Okay? But you can do things topically, like a little topical steroid for a couple of weeks, as you are reducing the edema to help decrease the effect of the dermatitis on the tissue. You may need to debride necrotic tissue out of the ulcers, and so good wound care. But number one is you have to start treating the edema. And I get a lot of referrals of patients that have had excellent wound care to the ulcers, can't complain about that, but no one controlled their edema, and so they may not have healed. Some of them will heal if they're not that bad or if they're hospitalized for a long period of time, but they'll return. The ulcers will return because nobody's controlled their edema. Okay. The way to control edema is through venous compression. We have to return the proper flow to the veins. We have to augment venous flow. We aren't yet complex enough to replace those veins and valves, although they're working on it. We may be able to someday be able to repair the valves. And there's some institutions that are trying to do that. But right now what we have to do is we have to augment the flow that you've lost in the veins and get the venous flow to start happening more normally. And the way we do that initially or acutely is through different types of bandages that are specially made to augment flow. Okay? One thing I want to tell you, and this is another one, I made the same mistake when I did primary care, is if this patient has venous edema or lymphatic edema, if you give them diuretics, they will get worse over time. Okay? Now, if they are getting diuretics because they have pump failure, that's totally different. That's very appropriate. Pump failure, heart failure, they're backing up fluid because of their pump. But if it's because of venous edema, when you first give them diuretics, they'll get better for a couple of weeks, and then they won't notice any difference, and then they'll start progressing and getting worse again. But for some reason, we hang on to that initial follow-up. Oh, I was better. It got better. Now let's think about what diuretics do. Remember, diuretics are going to extract, it's going to cause your kidney to extract fluid, right? Okay, and that's exactly what will happen to these patients. Now remember, the problem that they're having is they're leaking plasma, which has got water in it, but it has protein and other cellular debris. So if you start extracting the water from the legs and that plasma, what's going to happen? You're going to start concentrating the protein, right? So you actually start concentrating that protein, which is going to cause more inflammation, more of the symptoms to progress. So long-term diuretic use in these patients that really have venous stasis actually accelerates the destruction of the tissue. It accelerates it because it concentrates the plasma, the protein in the tissue, which causes faster hardening of the tissue and more inflammation. So we want to avoid diuretics in these patients unless they're on diuretics for their hypertension or their cardiac failure, and of course that's needed for that. Okay, so what we're going to do is we're going to reduce the edema. One of the things we don't want to use is ACE wraps. This is somebody who's just in an ACE wrap. And ACE wraps, of course, get lose their elasticity very quickly. They are not gradient in nature. Does everybody know what gradient compression is? I didn't. Okay. Gradient compression is it is actually developed by an equation called the Laplace equation. Anytime you wrap a cylinder with the same consistency, in other words, you wrap it with the same pressure all the way around, and if it's a cylinder, if that cylinder, wherever that cylinder is the smallest, has the smallest circumference, if you wrap it with the same tension, the place where the circumference is smaller will have the highest pressure. Where that cylinder is the widest, if you wrap it with the same pressure, it will have the lowest pressure. Most legs are the skinniest at the ankle and widest at the calf. Okay? So, if you have a gradient wrap on, this wrap, the pressure is going to be the highest here. Okay? It'll be the lowest up here, even though you put the wrap on with the same pressure. And in between, it's going to go from high to low, so it's going to be gradient. It's going to have a pumping action in that direction, right? That's the Laplace equation. And that is the idea behind gradient compression. There are dressings that you have access to that are designed to give gradient pumping compression that will help augment venous flow and get that blood to flow back towards the heart where it's supposed to. And that's the idea behind gradient compression. ACE wraps will not produce gradient compression. So we try to avoid ACE wraps if at all possible. There are several types of wraps that are out there. The oldest, I think it was developed in 1898, is the Uniboot. Still very useful, very inexpensive. And the Uniboot is a short stretch gradient compression. It's put on, and we nowadays usually will also put a layer of Coban over it. And what it does, short stretch does not actually put pressure on the leg. What it does, you put it on so it's snug but not too tight, and it will not put pressure on the leg. But what happens is you put it on when the leg is relaxed and the patient is laying down. When they get up and start walking, their muscles will contract. The size will get bigger. They'll abut the Una wrap. The Una wrap won't let them spread out, but what it'll do is it'll give a propulsive action of the muscle, so it augments the strength of your muscle in your leg and augments the venous pump. And that's the oldest type of compression wrap that there is, but it's relatively inexpensive and it's very useful, especially in ambulatory patients. Okay, so it can still today treat very effectively. We usually put a little Coban around that. And you have to have somebody that's done this to kind of show you the first time. I know those people that rotate with us will often at least get to see these put on, and sometimes will actually put some on. Second generation wraps are things like Profor. Okay, there's several other brands, and they are a wrap that actually, when you put it on, it has elastic compression. But when you put it on in a gradient fashion, it will not only pump fluid when they're resting, but it'll pump fluid when they're walking, so it pumps fluid all the time. And there's a 3-layer and a 4-layer in this second generation wrap. They were developed from the 90s, the 1990s, when we really started looking at these wounds more. And the Cochrane report says this is much better than an Una boot. Okay, when you look at the Cochrane report on modalities, they recommend what's called an active stretch type of gradient compression. You have to learn how to put these on, but essentially you put them on and they will pump, and you leave them on for a week. The patient will have pumping action when they're not walking, when they're walking, and it will start pushing all the venous fluid out of the leg. It will return the normal venous flow, and then what will happen is the lymphatics will start catching up on all the fluid that's there, and the size of the leg will start decreasing, and you start getting the edema under control. And then I don't have a picture of it, but today there's a third generation, which is it's made by the same company that makes Coban, but it's called Coban 2. It's a 2-stage dressing, and we found it to be more comfortable for patients and very effective, and so it's came out about 1.5 years ago. We were the beta test site for it, and it's been very effective, and patients like it even better because it's even more comfortable. Okay, so long stretch, that's what the newer ones are called, long stretch, and you've got those in lots of different brand names: Profor, Cetapress, Dynaflex, and now Coban, which is what's the name of the company that makes Coban? It'll come to me, but anyway, they now have what's called Coban 2, which is the newest generation. And these are all in your notes. Okay.
Can you put those exactly, like if you have a venous ulcer, you put them directly on top of stuff?
You do? Just put, you can put a little dressing over it, but generally they work as a dressing themselves.
And you find that for leaky legs, the Profor, the 4-layer compression is a little bit better just because of the exudative nature. I always find when I put Una boot, even when I say I want them on 3 days, it seems like...
Yeah. Well, let me tell you, the first week, no matter what, you're going to have junky dressings you take off because you're starting to mobilize the fluid out. But if you stay consistent, see, a lot of doctors give up after that first week. If you stay consistent and you start getting the fluid out, pretty soon the ulcers will quit leaking because now you've got a skinny leg, you don't have all that excess fluid, so it's not leaking out anymore. So you've got to get past that first week or two when you're mobilizing the fluid out of the leg, and then the wounds will quit oozing. Not only that, but now your leg is skinny and the wound now is back to its normal architecture to the arterial supply. Now it's getting good oxygen, good nutrition, and it starts healing. Now your good wound care with your weekly follow-ups will start working.
So do you find, I mean, just practically speaking, if someone's sort of, if you put the Una boot on day 1 and then by day 2 it's just kind of leaky and it's kind of falling off, you then just replace it earlier for the first week and then... You
can replace them a couple of times the first week and then after that. Now sometimes we will actually, we make a lot of different modifications and we can do that because we see so many patients, but we also on some will put a little bit of the crepe layer first on there. But work with some people that have done this, and then you get a feel for it. So
you're saying to do it for 4 weeks?
no, it's you have to do it. You have to do it until you control the edema. The average is anywhere from 2 to 4 weeks. But then when you have an ulcer that you're healing, the ulcer may take a little bit longer than that to heal. So you'll continue keeping the legs wrapped weekly until the ulcer is completely healed. They're going to complain about not being able to take a bath. Send them over to get a cast cover from one of the DME stores, and they're made to be waterproof if they use them right, and they can take a shower. Once you get the edema controlled, the wounds will start healing. Then all of your concepts of wound healing will start working. You know, things like getting out dead tissue. You may have a topical antibiotic you're putting on there. All of those things will start working because your edema, which is the big evil factor here on why it wouldn't heal, is now controlled. And so now all of a sudden your wounds are going to start granulating normally, they're going to start epithelializing, and they'll just start closing down for you. So it's amazing to see that happen. I get patients that, you know, it's like 10 years with venous ulcers, and they go, well, how come nobody sent me to you before? And I said, I don't know, you're here now, let's fix you, and there. It's because everyone did good wound care, but they didn't control the edema. Okay, once you control the edema, you get them healed, then you've got to maintenance them. And maintenance is putting them in gradient stockings, not tet hose. Okay, tet hose are not gradient stockings. Tet hose are anti-embolism. They do have a little bit of, they run around 18 millimeters of pressure, but they're really made to reduce clotting in the calf. Okay, they're not made to use as gradient compression. But they're inexpensive, they're all over the place, so I see a lot of patients come to me in tet hose. Okay? That's not a good thing to keep their edema chronically under control. So for maintenance, you're going to eventually have to get them in a gradient compression stocking. And the stockings are made to do the same thing. They're built on the Laplace equation. Okay? So they continue to augment proper flow in the veins and keep the edema controlled. They have to wear them. Usually I say when they get up in the morning, they can take their shower, but very soon they need to put on their gradient stockings. Some of these patients will start swelling within a matter of hours being up. They need to put them on, they'll wear them throughout the day. They have to pull them back up if they fall down a little bit so that they won't bunch at the ankle. And then at the end of the day, if they are patients that truly stay in bed, if they get up once or twice a night just to go to the bathroom, that's okay. But if they're truly patients that stay in bed, they can take their stockings off. I always recommend they have at least 2 pairs, 1 pair to wash and a clean pair to wear each morning. And the next morning they repeat the cycle. If they are insomniacs or frequent get-out-of-bedders, they need to wear the stockings straight through and change them first thing in the morning whenever they do their bath or shower. Okay? Over-the-counter gradient compression stockings are what people like yourselves should be wearing. They are meant to prevent you from getting venous incompetence in the future. They produce about 20 or less millimeters of gradient compression. You can get them at drugstores, Walmart, and they are preventive. Okay? Nurses should be wearing them, physicians should consider wearing them, policemen, anyone who's up on their legs a lot. These over-the-counter will not treat clinically significant venous stasis, meaning venous stasis that has caused ulcers or any other clinically significant signs. You need a little stronger class stocking. A class 1 stocking, also called 20 to 30 millimeter stocking, is a little bit higher gradient compression. It's for varicose veins, light edema, leg fatigue, and I'll sometimes use it in the non-ambulatory patient who has venous stasis because they're not upright all the time with gravity helping produce the edema. So they often can get away with a class 1 stocking. The most frequent stocking that I prescribe is a class 2, which produces 30 to 40 millimeters of pressure at the ankle, which is normal. That's what we do with healthy veins. We have 30 to 40 millimeters of pressure pumping action when we walk. And so a class 2 will produce this action, and it's used for the majority of the patients that I have that have clinically significant disease will be in this stocking. Okay. A few I will put in class 3. They're usually my younger patients, my ones that are still working full-time, the air conditioner repairman who had problems with ulcers. There's several people on TV that you've seen on TV that are still on TV that I've treated, and they're very active people, and they're in class 3. There's a couple of anesthesiologists in town I put in class 3. Those are very active people, usually in their younger ages, 30s, 40s, or 50s, and they're still full-time. And that's going to produce 40 to 50 millimeters of mercury at the ankle and have even a higher compression. Class 4 I've only used once, and that's somebody that had a very severe congenital problem. And those are like burlap, and they're very hard to put on. So most of your patients will be in class 2. We've perfected this in that we put them straight from the wrap once everything's healed right into their gradient stockings. The more control you have on them getting in your gradient stockings, the better their long-term results will be. If you hand a patient a script for a class 2 gradient stocking and say, I'm cutting these wraps off, go straight over and get this, 50% will never fill their script. Of the 50% that do, they'll get 50% of those will get the wrong thing given to them. So now you're down to 25% of patients that actually get what you sent them for. Those 25%, it's unlikely that the 16-year-old kid at the drugstore is going to give them good instructions on how to use them. So almost 100% of them will be non-compliant at the end of 6 months with their stockings. If you have a way to get them into the stocking straight from your treatment modality, right into the stocking, in our center what we do is they will come in, we take off that final wrap, our stocking fitter is there, we fit them, we put them in, we educate them. Now it's, God, it was so important. They didn't even let me leave the clinic without these stockings. And look, Dr. Kimbrell talked to the stocking fitter, and he threatened my life if I didn't wear these faithfully. Actually, I don't, but I really stress that they need to. And the more you control and stress the importance, the higher the compliance is. Even with that type, we still have about 10 to 15% that will become non-compliant. But that's a lot different. That's what, 85+% that are compliant. And then they have to change the stockings out in 6 months. The elasticity wears out in 6 months. If they buy a pair and store them for 6 months, the elasticity is gone in 6 months. It's like a pair of underwear you haven't worn for a year, and you pull them out and wear them, and you go, why the heck why is the little elastic crunching and not, your elasticity has decayed, and it's the same thing with these stockings. After 6 months, they decay. So you want to send them to a place that has fresh stockings, that they don't have them sitting up there for 6 months, because they actually expire at 6 months. The fibers start losing their, and these old patients, they pay money for that stocking. They'll buy new ones, but they'll save those old ones because they don't look too bad. And they'll come in to see me, and I'll say, why is I saw you a year ago, and your leg is swollen again. And they'll have their stocking, and I'll say, did you buy some new stocking? Oh, yes, sir. I bought them at 6 months. Where are they? Well, they're in my drawer. Well, how come? These were so much easier to put on. So they technically bought some. They just didn't change them over. And so you need to make sure that they do that. And we have a very high compliance rate. And for us, the insurers have noticed that. They notice that not very many of our patients recur, and so they actually send us. I get medical directors from Humana and stuff that call their physicians and say, can you send them over there? And it's purely because they see that there's not this recurrent cost every 6 months of healing these new ulcers. And when you go out into the private practice world, that's going to be important. It's also important for your patients. Okay, so the advantages of gradient stockings: it reduces ambulatory venous pressure, increases venous filling time, improves your calf pump function. That's the main thing. And it's you want to avoid using tet hose, right? Okay. There's lots of different manufacturers. Everyone knows the name Jobst. because they're one of the first ones, and it's kind of like McDonald's. You know, we all know McDonald's. Even though there's a lot of hamburger places out there. But actually, some of these other companies like Juzo and Sigvaris and so forth have much more comfortable type of stockings. Job's has usually a very thick stocking, although they've gotten better. But these other companies have had to compete with Job's, and so they often have come out with some very innovative, more comfortable, lighter weight, but still equally effective. And our stocking fitted carries multiple lines, so we can get the right thing. And that says, the common reason for treatment failure is, number one, you can't see it, inadequate edema control. Number two, only treating the wound and not treating the edema. Okay? Then misdiagnosis, no intensive follow-up, and inadequate or no patient education are common reasons for failure in these patients. Okay? So in conclusion, we're seeing, as our population ages, we're going to see more and more. It's already the number one reason a patient has a non-healing wound, and it's going to become a larger group of patients because we're all getting older, we're living longer. Okay? Counts for 70% of lower extremity ulcers, so it's kind of like back pain. You know, there's a lot of people, you know, back pain is very common, but not very many people really know how to treat back pain. If you learn how to treat venous stasis, you're going to have a huge group of your patients that are going to be happy with your care, and they will, if you treat them, they will come. It is a treatment challenge for many places because it takes resources, and I know not everybody will be in an environment where they have the resources to do this effectively. But remember, compression therapy is the cornerstone of treatment. And over 80% of patients can be successfully healed, and only a few will need to go to any kind of venous surgery, which I didn't cover this time, but we do occasionally split thickness skin graft some of these patients who fail to epithelialize. And occasionally in someone who, even though we've done everything right, they continue to recur, and I feel comfortable that they're compliant. Occasionally we'll go and have them have the SEPS procedure, one of the procedures to try to surgically reduce their venous pressure down there. But that's a small group of patients, and we've got an agreement with a group called Peripheral Vascular Associates who does those patients for us. But the vast majority of our patients we control by treating the way I've just discussed with you today. Questions?
Have
Yes,
you
sir.
seen any CSF exacerbations?
You can. If you have a patient who has congestive heart failure and is very tenuous anyway, well, you are causing increase of venous flow back to the heart. Those patients can have an exacerbation. And so one thing I do is if they're tenuous, I call whoever's treating their congestive heart failure, see if we can tune them a little better, and then we'll slowly, I may start at a lower compression and slowly reduce their edema. But that's possible, yes.
I have a series of questions. One is about prevention in the patient with severe venous insufficiency but no ulcer. And I mean, venous insufficiency up to the hips.
Right.
Yeah. So the other question is when do you use diagnostic modalities in the differential between venous and arterial, specifically ABI? And the other is if you
Good questions.
and you can give some words about post-thrombotic syndrome. I did a review recently. Most of the papers that I found was from Dr. Khan, if I'm not wrong, from McGillis in Canada, that they don't have like the definitive therapy.
Mm-hmm. Right. First question is preventive. If they already have venous stasis, the way you prevent them from getting an ulcer is to treat their venous stasis with gradient compression. Get their edema under control. There's gradient stockings that will go all the way to the hips. Okay, and if they control their edema, they have a much lower risk of getting chronic ulcers. Okay, and so remember, ulcers are a complication of uncontrolled venous stasis. If you catch them before they get to the non-healing ulcer stage, treat them. Get their edema under control and show them how to keep it controlled, and they'll have a reduced risk of venous
Do
ulceration.
you add aspirin in those patients?
Do I what?
Do you add aspirin or just the compression?
I don't add aspirin for venous problems. I mean, if they have an arterial problem, they may need aspirin. You know, if they have arterial insufficiency, or they may. But aspirin is not shown to change venous flow. Okay, good question. And then I think your other question was,
The uses of ABI.
oh, ABI, yes. And in my long lecture, I talk about that. Ankle brachial index is a way to screen for significant arterial disease. And remember, I told you 20% of patients with venous ulcers will have concomitant arterial disease. An ankle brachial index is a good way to get a quick handle on the extent of their arterial disease. Normal, what's a normal ABI? 0.9 to 1.1. Okay. Greater than 1.1 is abnormal, and less than 0.9 is abnormal. Now, you don't usually have significant problems with arterial insufficiency. We're born with more blood flow than we need until you get down below 0.8 in your ABI. So any of our patients that are 0.8 to 1.1, they'll tolerate gradient compression. I have a group of patients that are between 0.5 and 0.8. They have arterial disease, significant arterial disease. Some of those patients have already been revascularized. They're not going to get any better. In those patients, I'll use something like a Pro4 Light or an Uniboot, which puts less pressure, so you're compensating for that arterial disease, but still has some edema control factor. So that's a good question that you asked. If you have someone with significant arterial disease where you're seeing both venous and significant arterial ulcers, you need to send them to see whether there is a surgical option to improve their arterial flow. Okay? If the answer is no, we can't help them from an arterial standpoint, or no, they've already been maximally revascularized, or no, they're too old and I don't want to risk it, then you want to still approach that, but you're going to have to use the lower compression dressings. Again, Pro4 Light or Una Boot or something like that doesn't have a high compression rate, and see if you can get that under control. Good question. And those are things, what I would recommend is when you get that complex of a patient, you probably want to seek someone who really is set up to treat that higher level of complexity on there, is my suggestion to you. But your straightforward venous patient, you guys have the ability to treat if you have availability of these things. That part I can't tell you, but you can treat these patients. At the very least, I want you to understand how they should be treated so that you can make sure that they get sent for proper treatment if you're unable to because your facility doesn't have the resources for that. Okay? And I mean, we do that all the time. You know, as long as you know to recognize kidney disease and so forth and where they need to go, you do the patient a favor versus not understanding that they need to go and get treated somewhere that treats that. So either way, hopefully you benefited from hearing this. Any other questions in the audience? Thank you. If in the future you want to hear about some other wound-related stuff,
I've got you under my skin. I've got you deep in the heart of me. So deep in my heart that you're really a part of me. I've got you under my skin. I try so not to give in. I said to myself, this affair never will go so well.